Welcome to this session of the topographic anatomy of the lower limb, where in this particular session, we are going to look at nerves of the lower limb. Before we look at nerves of the lower limb, I'd want us to orient ourselves on the anatomy of a spinal nerve. So spinal nerves are nerves that arise from the spinal cord. They are usually about 31 pairs of nerves. 8 pairs arise from the cervical region, named C1 to C8. 12 pairs arise from the thoracic region, named T1 to T12. That makes 20. 5 pairs from the lumbar region, named L1 to L5. 5 pairs from the sacral region, named S1 to S5. So if you add to the initial 20, that's 25 and 30. Then 1 pair from the sacral region. Most of these spinal nerves will be organized like this. That from the spinal cord, there'll be multiple rootlets on the ventral aspect and multiple rootlets on the dorsal aspect of the spinal cord. So you can just call it the ventral rootlets and the dorsal rootlets. The ventral rootlets carry efferent neurons from the ventral horn of the spinal cord, having somatic motor function for innervation of skeletal musculature. But they also arise from the lateral horn of the spinal cord. The lateral horn of the spinal cord is for visceral motor function, for innervation of smooth muscle, for innervation of skeletal muscle, for innervation of smooth muscle, cardiac muscle, and perhaps glands. Visceral motor function is basically autonomic function. So to bring it to context, the ventral rootlets carry both somatic motor function as well as visceral motor function. Those rootlets join to form the ventral root of the spinal nerve. The dorsal rootlets, on the other hand, carry sensory neurons that enter the spinal cord. These sensory neurons will be structurally pseudo-unipolar neurons, having their cell body around there, known as the dorsal root ganglion, and those central processes of these neurons entering. So this is what we call the dorsal root of the spinal nerve. And their rootlets are not indicated here, but there'll be multiple rootlets entering the posterolateral aspect of the spinal cord. The swelling associated with the dorsal root is known as the dorsal root ganglion that houses the cell bodies of the pseudo-unipolar sensory neurons. This dorsal root join with the ventral root of the spinal nerve to form a single spinal nerve here. These are the ones we are saying are 31 pairs. We have on the right and the left side. Because the ventral root had fibers which have somatic motor function as well as those ones which have visceral motor function. The ones with the visceral motor functions have very interesting ways of communicating. Some of them may give you preganglionic fibers that join the sympathetic chain of the spinal cord and then exit again. How they join the sympathetic chain will be that the preganglionic fibers that join the chain constitute what we call the white ramus communicants because they are myelinated. But the postganglionic neurons that exit in the chain, this side has that. The postganglionic neurons that exit the chain exit via the gray ramus communicant. Now, that aside, that's more about autonomic nervous system. Let's go back to the anatomy of a spinal nerve. So a spinal nerve is formed by both the ventral and the dorsal root joining. This single spinal nerve divides mainly into two. Most of the time, one branch is a bit small and it goes behind. We call it the dorsal ramus. The term ramus means a branch. The dorsal rami, the plural of ramus is rami. The dorsal rami tend to be segmental nerves, to mean they supply the body in their respective segments. They don't move so much away from the segment. They'll tend to supply the musculature of the back if they are motor in function, or the skin of the back if they are sensory in function. Remember, this single spinal nerve is now a mixed nerve having both motor and sensory function. And so when it's dividing into two, the dorsal ramus will have both motor and sensory components. Just like the ventral ramus will also have both motor and sensory components. Now, the ventral ramus supplies structures which may migrate a lot. For that reason, there's some segments where the ventral rami form intertwining of several nerves. The intertwining of ventral rami is what we call a plexus. Such plexuses involve intertwining of neuronal processes without necessarily synapses. We call them plexuses. These plexuses come about because of the structures which are being innervated having migrated from their original site embryologically to their adult positions, of course, still happened before birth. So as they migrate and change positions, the nerves that were attached to them will intertwine. I hope you understand what I mean. Such plexuses are common in some regions. For example, in the neck, we have cervical plexus. In the lower neck, so the upper neck has cervical plexus for innervation of muscles around the neck. The lower neck, we have the brachial plexus for innervation of the upper limbs, basically. So the structure of the upper limb must have migrated quite extensively and changed position. Their nerves therefore intertwine. Similarly, we have the lumbar plexus and the sacral plexus, intertwining of the ventral rami of spinal nerves for innervation of the lower limb, both in the lumbar segments as well as the sacral segment. Most of the time, the ventral rami may also divide into two: anterior division and a posterior division. So remember, the divisions are of the ventral rami. Anterior division, most of the time, will tend to supply the flexor compartments as well as perhaps the adductor compartments and maybe the pronator compartment. Then the posterior division will tend to supply the extensor compartments, the abductor compartment, and possibly the supinator compartments, generally speaking, not cast on stone. Now, having said that the ventral rami form plexuses as a result of migration and changing position, the ventral rami nerves will intertwine because of that, and that the lower limb is associated with such plexus. I want us to look at the plexus that result to innervation of the lower limb. We have two plexuses. The lumbar plexus arising from the lumbar nerve and the sacral plexus arising from the sacral nerves. So when you look at this is the lumbar plexus, how the nerves intertwine, shown in this particular image as well. And they have the sacral plexus as well here, how the nerves intertwine. Maybe this one shows it nicely from S1 there down. Now, important to note is that together, the lumbar and the sacral plexus contribute to the innervation of the lower limb. And so we can combine these plexus into one big one. We call it this nice name, the lumbosacral plexus. So the lumbosacral plexus, the plexus supply the lower limb structures. This image has color-coded some of the divisions of the ventral rami. You can see perhaps the yellow one representing posterior division of the ventral rami, while the other color, I want to use the term green, I have a feeling I might be wrong, represents the color code for the anterior division of the ventral rami. There are many nerves, terminal nerves, which arise from the lumbosacral plexus. You can see some of them have been named here. For example, you can see the big ones. Let me start with them. Sciatic nerve. You can also see the femoral nerve. You can see the obturator nerve. I want to insist on those ones because I want to talk about them more. But there are many others. Lateral femorocutaneous nerve, genitofemoral nerve, ilioinguinal nerve, iliohypogastric nerve. Those two may not quite supply a big region in the lower limb, but they're part of the lumbosacral plexus of nerves. On this side, we see the superior gluteal nerve, the inferior gluteal nerve, nerve to piriformis, nerve to quadratus femoris, nerve to obturator internus, posterior cutaneous nerve of the thigh, the pudendal nerve, and the like. So I want us to discuss some particular nerves that arise from the lumbosacral plexus and supply the lower limb. But before that, I want to encourage you at your own time to just look at an atlas again and review how this plexus is formed, and especially single out the nerves that I'll be mentioning. Before we discuss the nerves that I want to choose, I want to lay down a general framework on the template we use when you're describing a nerve from a spinal cord, a spinal nerve. 4 important parameters to highlight. The first one, of course, after knowing the name of the nerve, is where the nerve comes from. The origin of the nerve has two aspects to highlight. Where the nerve branched from. So for example, if it's a nerve arising from another parent nerve, then we name the parent nerve. If it doesn't, it's okay. You can name the plexus that it arises from. If it doesn't arise from the plexus, you can just mention the spinal cord. But then that brings us to the second concept, the root value. What's the root value of a nerve? The root value of a nerve refers to the spinal cord segment that contribute to the formation of that particular nerve. I've already told you about segments of the spinal cord. Cervical segment having 8 segments, C1 to C8. Thoracic segment having 12 of them, T1 to T12. Lumbar having 5, L1 to L5, sacral 5, S1 to S5, and coccygeal 1. So the segments of the spinal cord that contribute to the formation of a particular nerve constitute the root value of a nerve. And in the examples I'll give you, you'll understand that more. After talking about the origin of a nerve, then we talk about the cause of a nerve. We want to know where the nerve passes in the body. As we do this, we pay more attention on the anatomical relations of this particular nerve, especially the important anatomical relations of this particular nerve. And they'll be important clinically most of the time, or the surface landmarks of this particular nerve, because that's also of clinical importance. We talk about surface landmark, we're referring to how can we trace these particular deep structures from the surface of the body. What landmarks can we use to help us locate where this structure lies? So that's important to highlight. Then the other major thing talk about are the branches and distribution of this particular nerve. Remember, this nerve will be giving branches as it goes further and further away from the spinal cord, and therefore becoming smaller and smaller as it gets branches. Some branches are named. So we want to know the names of those branches. And those branches which are named also go to some particular target structures. Even if the branches are not named, they're still going somewhere. So the target structures constitute the distribution. Generally, we can classify or categorize the target structures into motor and sensory structures, or motor and sensory distributions. When you talk of motor distribution, we are largely referring to the skeletal muscles that they supply. It's more of the somatic motor distribution. Occasionally, this could be also visceral motor distribution. So when you talk of motor, most of the time to be skeletal motor distribution, in which case we just call them the muscular branches. Those are the ones that go to muscles. Well, within the muscular branches, you may also have sensory components, but we don't talk much about them unless it's very necessary. So a branch of a nerve that go to a particular muscle, you can just call it muscular branch. We know that within that muscular branch, there'll be motor function that cause that muscle to contract. But there'll also be some sensory fibers that carry sensory information from that particular muscle. It's okay, you just call them muscular branches, and that captures that very well. Other than the sensory that go to muscles, There are also sensory branches that go to skin. So we call them cutaneous branches. And there are also sensory branches that go to joints or the structures around a joint. We call them the articular branches. So again, generally speaking, the sensory branches are usually divided into cutaneous and articular branches. And we rarely talk about sensory branches to muscles because most of the time muscular branches have within them the motor and the sensory components for that particular muscle. We need to hear, we need to see that you understand that a particular nerve has some branches which are named. And if they're not, it's fine. If they're named, you tell us the names and what these structures apply in that distribution. Last but not least, the fourth aspect that you need to know about a nerve, the clinical importance of this particular nerve. And generally speaking, clinical importance of nerves capture the aspect of nerve injury and the manifestations of these injuries. Where is this nerve likely to be injured? If it is subcutaneous or near a particular bony structure that's subcutaneous, then it can be easily knocked from external force. That's a possible site of injury. If the nerve is passing through some narrow tunnel or narrow gap, it's a possible site of injury because it can be trapped into those particular anatomical narrow spaces. Whichever the cause of injury, what are the clinical effects of the injury of that nerve? When you think about clinical effects of injury for nerve, you need to remember what it supplies. So for example, if a nerve supplies a muscle and is injured, it may mean that that particular muscle will be paralyzed. So you need to not just tell us this must be paralyzed, but perhaps with some light then tell us which movements are impaired because you know the action of that muscle, or which deformities will ensue because you know if this muscle is paralyzed, then it's not contracting this particular manner. These other ones will override in their contraction. This joint will be deformed in this manner. So you want to know the motor manifestation of a nerve injury in form of those deformities. We, however, also want to know the sensory manifestation of a nerve injury in form of regions of the skin that lose sensation or that have disturbed sensation as a result of injury of a particular nerve. Remember, if a nerve is injured and the sensory nerve, it may not be able to carry sensory impulses appropriately from the site where it was going. So the outcome would be a loss of sensation from those regions. So if you know the distribution, let's say the nerve goes to the big toe. Even if you injure it in the thigh, and it's the only nerve that was supplying that big toe, then you lose sensations of the big toe. So you describe the region of the body. If this nerve was supplying muscles that cause the ankle joint to dorsiflex, for example, and is the only nerve that supplies these muscles that cause dorsiflexion at the ankle. If this nerve is injured, you definitely lose dorsiflexion. So the foot will be plantar flexed. That may have a clinical name, perhaps called the foot drop and the like. That's a motor manifestation of a nerve injury. To understand when you talk about nerve injuries, we'll be looking at the motor and the sensory effects of the injury. So with that in mind, I want us to begin by talking about the largest peripheral nerve in the body, the sciatic nerve. And we'll discuss sciatic nerve in the context of what I've just told you. We'll look at the origin, the cause, branches and distribution, and the clinical manifestation of injury. Let's begin by the origin of the sciatic nerve. So sciatic nerve arises from the lumbosacral plexus, of course, among other nerves that also supply the lower limb that arise from the lumbosacral plexus. The root value of the sciatic nerve is L45S123. So these are the spinal cord segments that contribute to formation of the sciatic nerve. Of course, when it's formed, it is way within the pelvic cavity. Now let's talk about its cause. Having been formed way inside the pelvic cavity, how does this nerve reach the lower limb? The sciatic nerve enters the gluteal region via the greater sciatic notch or the greater sciatic foramen. The greater sciatic foramen is somewhere around here. Remember, the greater sciatic foramen is divided into two by the piriformis muscle. The two are the suprapiriformic compartment and the infrapiriformic compartment. The nerve passes below piriformis, so the infrapiriformic compartment. After traversing the infrapiriformic compartment, the nerve enters the gluteal region. Occasionally, the nerve may pass through piriformis, or it may divide into two, and one part pass through piriformis. Most of the time, the whole nerve is just single and pass below piriformis. After passing below piriformis, it will be now in the gluteal region, deep to the gluteus maximus muscle that has been removed from this particular image so that we can see the deep structures. But it will be posterior to most of the small lateral rotators of the thigh. Other than piriformis, the others will be anterior to the nerve. So superior gemellus, obturator internus, inferior gemellus, the quadratus femoris, and deep to that, the obturator externus. Those muscles lie anterior. Further anterior to that is actually the hip joint. So the hip joint is also anterior to the nerve. In other words, the sciatic nerve is posterior to the hip joint. And that should speak something clinically. That if the hip joint was to dislocate posteriorly for whatever reason, then the sciatic nerve will be at injury, at risk of injury. This shows you that anatomy, that the nerve is behind the hip joint as well, having removed the muscles of the gluteal region so that we can see the relationship between the nerve and the hip joint. From the gluteal region, the nerve exits the gluteal space somewhat midpoint between the greater trochanter on this side and ischial tuberosity on this other side. that may constitute a surface landmark of the sciatic nerve. A point midpoint between the ischiotuberosity, which you can palpate on a patient, and greater trochanter, again, something you can palpate on a patient. Somewhere in between that, the sciatic nerve will be underneath. So that's a surface landmark. Well, the other surface landmark, especially the entry point to the gluteal region, will be somewhat midpoint, again, between the posterior superior iliac spine, that point, and again, ischiotuberosity, midpoint. So if somebody was to ask you to trace the surface marking of the nerve in the gluteal region without necessarily dissecting, then look for 2 points. One point, the midpoint between posterior superior iliac spine and the ischiotuberosity, midpoint, and another midpoint between ischiotuberosity and greater trochanter. Join those 2 points with a line, except the line is not very straight. The line is slightly convex laterally. So that the surface marking of the sciatic nerve in the gluteal region. This shows you the sciatic nerve as it enters the thigh, midpoint between ischiotuberosity and greater trochanter. After exiting gluteal region, it enters the thigh deep to the hamstring muscles, and especially the long head of biceps femoris, which crosses it, as you can see here. The nerve goes all the way to the apex of the popliteal fossa, somewhere here, where it eventually separates or divides into 2 divisions. One large division, the tibial division, is more straight, almost like a continuation of the nerve through the popliteal fossa. The smaller division is the lateral division, the common peroneal division, which takes a tangent laterally along the common tendon of biceps femoris, going laterally. Now, one important thing to take note of, we usually consider sciatic nerve as actually 2 nerves within one common sheath. These 2 nerves are the tibial nerve and the common peroneal nerve, but they're usually found in one common connective tissue sheath, in which case the 2 nerves can separate anywhere along the path of the so-called sciatic nerve. They may separate within the pelvis, they may separate within the gluteal region, they may separate within the thigh. But as a matter of overall fact, by the time the whole sheath is at the popliteal fossa, they have already separated. Now, if the 2 nerves separate within the pelvis, the common peroneal division may pass below piriformis or may go through piriformis. If there's no division within the pelvis, most of the time the whole sheath will just pass below piriformis. Again, think about that. That could have clinical impact. All right, let's say something about blood supply to the sciatic nerve. Because it's such a big nerve, it has blood supply. In the gluteal region, there's a branch of the inferior gluteal artery that supplies the sciatic nerve. We call the companion artery to the sciatic nerve. In the back of the thigh, the longitudinal anastomosis formed by the perforating branches of the profunda femoris artery provide blood supply to the sciatic nerve. What are the distribution of the sciatic nerve? The branches and distribution. So we don't have branches of sciatic nerve in the gluteal region in the context that I've described. In the thigh, however, we have some branches. The tibial division of the sciatic nerve gives muscular branches to the hamstring group of muscles. So that means the long head of biceps femoris, the semitendinosus muscle, as well as the semimembranosus muscle. In addition to that, this tibial division also supplies the hamstring component of the adductor magnus muscle. Or if that sounds ambiguous, we can say the tendinous component of the adductor magnus muscle. All right, so adductor magnus is a big muscle. It has two components, a part that inserts in form of a tendon and the part that inserts along the linea aspera, the adductor component. The tibial division supplies the tendinous component, the longer components of the muscle. The common division, the common peroneal nerve division of the sciatic nerve supplies the muscular, gives you a muscular branch that supplies the short head of the biceps femoris muscle. This is in the back of the thigh. After this, we have said that by the time it reaches the popliteal fossa, the nerve now has two divisions, the tibial division and the common peroneal division. Those two terminal branches will course through the popliteal fossa and enter the leg, and their terminal branches reach even the foot, supplying multiple things there. And I'll want to discuss them as perhaps other nerves, discussing them in terms of their origin, root value, cause, the branches, distribution, the landmarks, and the clinical anatomy. Now let's look at this. So this shows you the tibial nerve as it comes from the sciatic nerve. I told you it's the most straight, more bigger one, traversing the popliteal fossa. So tibial nerve runs in the posterior aspect of the leg, supplying the posterior compartment of the leg, gives you multiple sensory branches, eventually reaching the sole of the foot through the tarsal tunnel. Tibial nerve supplies, therefore, the plantar flexor compartment of the leg, as well as supplying the plantar aspect of the foot in terms of the motor distribution. Its named sensory branches would be the sural nerve, which is given around the popliteal fossa, and of course, its terminal branch is down here. It terminates by giving the medial and the lateral plantar nerves, which have both motor and sensory functions. You can check which particular muscles in the foot are supplied by medial plantar and which ones supplied with the lateral plantar. The common peroneal division, on the other hand, is given and causes laterally along the margin of the biceps femoris tendon. The nerve winds around the fibular neck, just below the head there, and that's a common site of injury to the common peroneal nerve, fibular neck. It's subcutaneous at that point. It's also very close to the bone at that point. It can be knocked easily. If you have fractured the femoral of the fibular head or neck, it can also injure the nerve. The nerve then divides into superficial and deep peroneal nerve. The superficial peroneal nerve enters the peroneal compartment of the leg, supplying the two muscles with the lateral compartment there before it emerges as a cutaneous nerve supplying the dorsum of the foot. The deep peroneal nerve, on the hand, entered the anterior compartment of the leg, supplying the four dorsiflexor muscles, merging with the anterior tibial vessels, also enter the dorsum of the foot. In terms of its sensory distribution, the deep peroneal nerve will mainly supply the skin of the first web space there on the dorsal aspect. The superficial peroneal nerve, also known as superficial fibular nerve, will supply the distal lateral aspect of the leg, as well as most of the dorsum of the foot, except the nail beds of the toes. The nail beds of the toes tend to be supplied by nerves which are on the plantar aspect. So the medial and the lateral plantar nerves are the ones that will contribute to innervating the nail bed of the respective toes. This is because of how the nail develops embryologically. Initially, the plate is more of a plantar or a ventral structure before it migrates to become a dorsal structure, and it migrates with its own sensory innervation. That's why the nail bed, which is a dorsal structure, receives innervation from a ventral nerve rather than a dorsal nerve. That concept applies both in the feet as well as in the hands, which means in the toes as well as in the fingers. The concept of the ventral nerves are the ones that are participating in innervation of the nail beds. Now, the two nerves, tibial nerve and common peroneal nerve, have sensory distributions. I've already told you about the sensory distribution of the tibial nerve. Other than the sural nerve, which is sometimes called the medial sural nerve, tibial nerve also has the superior medial genicular nerve, the middle genicular nerve, and inferior medial genicular nerve. Those are articular branches of the tibial nerve to the knee joint. Superior medial genicular, middle genicular, and inferior medial genicular. The common peroneal nerve, on the other hand, has also sensory branches. It has the sural communicating nerve, which is also known as the lateral sural nerve, to join with the medial sural nerve, which is the main sural nerve, and the two, again, ambiguously form the sural nerve because they unite. their union is usually much lower down. Other than that, the common peroneal nerve also gives us the lateral cutaneous nerve of the calf, which supplies the skin around this region. Lateral cutaneous nerve of the calf. It also gives the recurrent genicular nerve. That's more of an articular branch, which supplies the superior tibiofibular joints. The other articular branches of the common peroneal nerve are the superior lateral genicular nerve and the inferior lateral genicular nerve. So I've mentioned several articular branches. Remember, the ones with the M arise from the tibial nerve. Then the ones without M arise from the common peroneal nerve. The image here shows you the cutaneous distribution of the various nerves on the sole of the foot with their various territories. Lateral margin being contributed by the pseudo nerve, directly inferior here being contributed by tibial nerve and its terminal branches, lateral and medial plantar nerve. And then on the medial margin of the foot being contributed by saphenous nerve, a terminal branch of the femoral nerve, as opposed to terminal of the sciatic. Take note that on the dorsum of the foot, the first web space is by the deep peroneal nerve, and that's a nice way of confirming the integrity of the deep peroneal nerve, the sensory component, by just pricking there. The rest will be by the superficial femoral, so superficial peroneal nerve, the rest of the dorsum of the foot. Remember, lateral margin is sural, medial margin is saphenous nerve. So let's talk about clinical relevance of the sciatic nerve. I've already mentioned that the sciatic nerve may divide within the pelvis. If that happens, the common peroneal division may pass through piriformis. If it indeed passes through piriformis, the piriformis may entrap it. That's not the only cause of entrapment of the nerve by piriformis. Sometimes you may just have also a hypertrophic piriformis, and so it can entrap the whole nerve, not just the common peroneal division. All in all, we call that piriformis syndrome. The symptomatology that arises from compression of the sciatic nerve or its component by piriformis muscle is called piriformis syndrome. Sciatic nerve is also at risk of intramuscular injury, intramuscular injection injury. If you give injection in the gluteal region, and especially perhaps in children, the needle may injure the sciatic nerve. This may happen if you gave the injection not so much on the upper outer quadrant of the gluteal region, or if the gluteal region didn't have adequate muscle bulk, and perhaps the needle you're using is very long, or if you just didn't orient your needle quite well in the gluteal region. Those risks increase much in children than in adults. So injury of the nerve by injection is something that has been noted. I'll leave it to you to think about what would the clinical effect of injury of sciatic nerve. Overall, think about the whole territory of distribution of sciatic nerve, which means you have to think about the main nerve or its even terminal component. You will realize that if you are to injure sciatic nerve totally in the gluteal region, that person may not walk at all, because you have affected the whole of the posterior thigh muscles, which means this person will not actually be able to flex their knee. But you'll also have paralyzed everything in the leg and foot. All the muscles of the leg and foot will be paralyzed if you totally injure sciatic nerve. So they can't dorsiflex, they can't plantarflex. Basically, they can't walk. You'll also lose sensations in many parts of the lower limb. You have to think about the sensory nerves, the cutaneous nerve that eventually came from the sciatic nerve. So things like the territory of sural nerve, the territory of the lateral cutaneous nerve, the calf, and the like will be affected. All right, that is sciatic nerve. I want you to revisit that and especially now into detail look at even the terminal divisions, the tibial division and the common peroneal nerve division. But let's discuss the femoral nerve as our second major nerve. So femoral nerve, as you can see here, we see it mainly in the femoral triangle, but that's not where it comes from. Femoral nerve arises again from the lumbosacral plexus, but in this case, specifically the lumbar plexus, with the root value L234. But the posterior divisions of the ventral rami are the ones that constitute the femoral nerve. So I'd already alluded to the concept of posterior divisions and anterior divisions of ventral rami of nerves. Femoral nerve come from L234 posterior division. The counterpart is obturator nerve that come from the same segment but anterior division. So this image shows you that concept of a spinal nerve arising from the spinal cord via two roots joining to form a single spinal nerve which is mixed. Then the nerve has dorsal ramus and ventral ramus. The ventral ramus is the one that gives you two divisions, the posterior division and the anterior division. So the femoral nerve is posterior division of segments L, 2, 3, and 4, while the obturator nerve will be the anterior divisions of segments, again L2, 3, and 4. Now we are following the green nerve there. What is its cause? The femoral nerve, once formed in the pelvis, will curve through the pelvic surface there on the surface of the muscle iliacus, pass below the inguinal ligament, between the muscle iliacus and the tendon of psoas major. In that groove, the nerve emerges onto the femoral triangle in the upper part of the thigh. Usually, that nerve will be outside the femoral shape. The nerve ramifies almost immediately. It divides almost immediately in the femoral triangle by giving several branches. It has muscular branches to the anterior muscles of the thigh. So the musculature in the anterior thigh are supplied by the femoral nerve. It also has cutaneous branches that is distributed to the skin. Mainly these branches go to the anteromedial thigh. We have the medial cutaneous nerve of the thigh, the intermediate cutaneous nerve of the thigh, and the anterior lateral cutaneous nerve of the thigh, all arising from the femoral nerve in this territory here. However, the nerve will also terminate by giving us a very long nerve we call the saphenous nerve that runs on the middle aspect of the leg and foot. So the saphenous nerve will also supply the middle aspect of the leg and foot. That is still territory of the femoral nerve. The saphenous nerve is considered the terminal branch of the femoral nerve. So that shows that territory quite well, a bit in light. Follow the ramification there with several muscular branches. You can see the cutaneous branches being shown there. And then this terminal branch going all the way as the saphenous nerve. At some point, it's within the adductor canal there, the saphenous nerve, then becomes subcutaneous. Now it can now start supplying the skin of the medial leg and medial foot. How about the obturator nerve? I've already mentioned that it's an anterior division of the same segment. So the origin of obturator nerve will be lumbar plexus, just like femoral nerve, with the root value L234, in this case, anterior divisions, as shown in that particular image. The obturator nerve is also within the pelvis. It's much medial in the pelvis, and maybe in the true pelvis rather than actually the lesser pelvis, which is also called the greater pelvis. It's in the true pelvis here. So the nerve exits the pelvic cavity by passing through a small opening above the obturator membrane, or a gap in the upper part of the obturator membrane, what we call the obturator canal. Remember that the obturator foramen has a membrane that covers it, which we call obturator membrane. There's a small gap of that foramen for the passage of the obturator neurovascular bundle, artery vein nerve. So the nerve passes through that to enter the thigh. This is the obturator canal. This is the obturator foramen, and this is the obturator membrane. So this is the obturator canal where the obturator nerve and artery pass. After passing, now the nerve enters the thigh. Usually in the middle aspect of the thigh, it will give branches. It splits into two. It's anterior and posterior division. The posterior division goes to those muscles, obturator externus, adductor magnus, adductor brevis, and sends a sensory branch to the knee joint. That's an articular branch. The anterior division, on the other hand, supplies most of the other adductor muscles. So adductor longus, again, it also supplies the adductor brevis. So adductor brevis receives twice, both from anterior and posterior division. It supplies the gracilis muscle. It also supplies the pectineus muscle. Those are the other adductor muscles. This anterior division also sends a sensory branch to the hip joint and also supplies a small skin on the middle aspect of the thigh, that region. Great, so this summarizes for us nicely the muscles supplied by the two divisions of the obturator nerve. Posterior division goes to obturator externus, adductor magnus, and adductor brevis before supplying the knee joint. The anterior division supplies the hip joint, but also supplies pectineus, adductor brevis again, adductor longus, gracilis, and sends a sensory branch on the middle aspect of the thigh. Clinically, the one I want to highlight is the concept of pain referral. That pain from the knee may be referred to the hip because of this, and maybe vice versa, because the obturator nerve supplies the two. Great. So that is obturator and its territory in a better view. Now, I've picked only 3 nerves. I want you at your own time to use the same model to work out the other nerves, the anatomy. Remember the template: origin, cause, branches and distribution, and clinical anatomy. But let me finish by just giving us a summary of the sensory innervation of the lower limb. Let's start with the skin of the gluteal region. So there are many nerves that supply the skin of the gluteal region. You can even divide this into quadrants. I'm doing this because there's some nerves we've not mentioned and some we mentioned. An atlas will give you a nice pictorial view of how the skin of the gluteal region is supplied. But yes, on the upper outer quadrant, more lateral or more anterior, we have the lateral cutaneous nerve of the subcostal nerve. It's a branch of the subcostal nerve. We also have iliohypogastric nerve contributing into that quadrant. These are nerves we didn't mention. But yes, subcostal nerve is a T12 nerve, iliohypogastric is an L1 nerve. They reach the gluteal region. On the much posterior aspects, on the superior aspect of the gluteal region, or much medial aspect, we have the lumbar nerves, so the lower lumbar nerves, as well as we have the upper sacral nerves. Much lower down, posteriorly, we have branches that arise from the posterior cutaneous nerve of the thigh. So they may give us some branches there, usually supplying a bigger chunk. On this lower side, then we can have the lateral cutaneous nerve of the thigh also giving us a branch. An atlas will help in that. How about in the rest of the thigh? So the anterior thigh predominated by branches of the femoral nerve, as well as the lateral cutaneous nerve of the thigh. In the leg, medially, saphenous, laterally, lateral cutaneous nerve of the calf, which is from common peroneal, but posteriorly, the sural nerve, which is contributed by both the tibial as well as common peroneal nerve. In the posterior thigh, the main nerve is posterior cutaneous nerve of the thigh. This one gives you territory of those nerves. Now, there's something called dermatome. Dermatome refers to a skin segment supplied by a single segment of the spinal cord. Occasionally, we can ask you to name the dermatome of this particular region. When you ask that question, we're just asking which spinal cord segment contributes to the innervation of the skin of this region. So again, at your own time, I want you to look at dermatomes of the lower limb so that you're able to pinpoint this is L1, this is S1, and things like that. For example, I can tell you that the anterior knee is about L3 there. This region, skin over the femoral triangle, is about L1 there. So look at the dermatomes of the lower limb as well. Great. I have tackled 3 major nerves. I'll want you to look at the other nerves: superior gluteal nerve, inferior gluteal nerve, posterior cutaneous nerve of the thigh, tibial nerve, common peroneal nerve, saphenous nerve, lateral cutaneous nerve of the thigh, and genitofemoral nerve. Your aim is to look at the origin, the cause, branching distribution, and the clinical anatomy. Use the template I've given. Thank you very much. So I'll end it there.